I started endoscopy in 2009, 31st of March. I invited Tom Hoogland because I was very skeptic about endoscopy, okay? And the thing I was facing as a resident at that time is the post-operative back pain when you do open surgery. And I thought, isn't there another way to do the surgery without having the back pain for the patient? And then I ran into the Maxmore system, and I invited Tom Hoogland. He came to me, and I selected 4 cases, complex cases. L5 is one, migrated, and so on and so forth. And he came to me, and we did 4 cases together, and I was really flabbergasted what he was capable of doing with the endoscope. And at that time, I said, well, this is the way I want to go. And then I started slowly to do surgery and from the endoscopic point of view. I've done almost 2,000 cases now, not 5,000 yet, but probably I will in the future. And I'm operating at my private hospital, Park Medicentrum, and I'm also at the Erasmus Medical Center as a neurosurgeon. So, the first case came to me, and it was a patient, 9 years old, at another academic hospital, being treated conservatively because everyone was thinking it will disappear. It will disappear. Just wait. After 1.5 years, it didn't disappear, and all of a sudden the patients came to my private hospital because they knew that I was doing the endoscopic surgery, and they asked me, can you do it with the endoscope? I said, well, I don't know. I've never done a case, 9 years old, and I have to discuss with our staff to get back up to do the surgery, okay? I went to our dean at the academic hospital, I explained it, and I asked them, what is your advice? And he told me, yes, you can do it, but it's dangerous, probably you do it better open surgery in the children's hospital, and so on and so forth. But the parents didn't want to have open surgery, which you can imagine in the 9 years old is maybe better to not to do so. Then I thought maybe we can do endoscopy in the children's hospital, but the anesthesiologist is not doing sedation. They don't want to do sedation. I was lucky, I had the anesthesiologist at the private hospital, a German guy who was also used to do children. So he said, for me it's no problem. Let's do it in the private hospital. So we did it in private hospital. So the patient came and yes. So you can see it's complaints on the left side. Patient has a contracture now, and parents are totally upset what to do. And we decided to do the surgery with the transforaminal approach. At that time, it was not being reimbursed in the Netherlands. So the parents did crowdfunding in the Netherlands, right, to do to pay for the surgery. This is a disc herniation, okay? Look how large it is, lasting for more than 1 year now, almost 1.5 years. So you can do interlaminar, of course. You can do open surgery, but if you look closely, probably what the colleague is saying also, Dr. Hura, that you can enter also from the transforaminal trajectory, okay? So we did that, and this is how we do the surgery. Patients are lying in prone position. I do my AP in lateral through AP triple, but this guy is very important. He knows how to sedate the patient. When we start, when we do the drilling, the patient is a little bit more deeper, okay? Once I pass the medial pericral line, I want the patient to become more awake. So they play with the sedation. It's not continuous at one level. It's starting from deep, going less deep, okay? So access points, we can discuss about it in the lab, but it's not always the case, you know. It varies. In a small patient like this 9-year-old, you cannot go from 14 centimeters. You will end up in the retroperitoneal space, okay? So you have always to think about where is my target, where do I want to enter, and what will my trajectory be, okay? So you see here, lateral with a lateral X-ray with a really large foramen. You can easily go through the foramen, but bone is your friend. There are two advantages to go through the SCP. The first one is you enlarge the foramen, so you are in the caudal part, so the risk of damaging the nerve is very low, and the patient is awake, so you'll get immediate feedback. The other thing is that your working channel will be fixed. It will not move. So you don't have the problem which you have in interlaminar. If you have a big window, you can go easily through the flavum, but you have to hold the working channel as well. I don't have to hold the working channel. So then you start SCP, you do the skin infiltration, Cambridge triangle here. Safe zone. You don't have to be afraid if you are there, okay? Then you start drilling, and all of a sudden, I'm in the spinal canal. Look, here. I'm in the spinal canal from the lateral point of view. But if you remember the MRI, what I told you is pushed posteriorly, okay? So if you enter in this area, you will end up in the disc herniation. And you see 8 millimeters drill, and then we can go easily to the contralateral side. Especially in L4, L5, it's more easy to go to the contralateral side. And this is what we see. So the left side is cranial, right side is caudal, 12 o'clock is posterior, 6 o'clock is anterior. Okay, and I do not use staining of the disc material, but probably if you start, it's wise to do it to recognize the structures. Okay. So here above you see the nerve already is coming. This is disc material. You can see it's moving already. This is epidural fat. And there you can see the nerve decompressed. But the disc in young patients is very stitchy. You cannot remove it in one big piece like he showed. It's piecemeal surgery. But you can.
It's chronic for more than 1 year. So.
Exactly. So, but clearly you can see this, the nerve root, which is pulsating. Is that enough? We don't know. Sometimes we see nerves pulsating and the patient is still having leg pain after surgery. So I'm trying to find out in my database what is the best way. Do we need to see the nerve? Do we have to see pulsations of the nerve? Is it enough to have epidural pulsations? I don't know. I have to look in the data, into the data more specifically. So this is piecemeal surgery, okay? And this is the post-op scan. Am I happy? Not totally.
When was this after surgery?
This is 6 weeks. 6 weeks after surgery. So you can see here the difference between here and there, but still there is some stenosis of the lateral recess. But the patient is happy. But probably in the future, this will become a problem. Okay? Let's see and wait. So this is the post-op, 6 weeks after surgery. Patient is happy, parents are happy, surgeon is happy, everyone is happy. But imagine if this didn't go as good as in this case. Probably I will never do another case for a second time. So, and that's what I'm trying to tell you. If you start endoscopic surgery, make sure you start cases that are relatively easy, okay? Don't take too much risk. If you take too much risk and you have complications in the beginning, you will stop. You will go back to the open surgery. So beware. Try to take your time and avoid complications in the beginning. We have all nerve damage, we have all dura tears, but not in the beginning. Okay? So this is my first case I want to share with you. So what about high iliac crest? A lot of endoscopic surgeons are telling you, if you have the high iliac crest, please go interlaminar. Please go interlaminar. If you read my paper in the BMJ, you can see that most patients we have operated were on L5S1, which is general practice. You see L5S1 followed by L4, L5, if you look at the statistical frequencies of those disc herniations. So, yes, you can, but it's about the planning. Where is your target? Where do you want to enter? And what is your trajectory? Okay? So if you have a high iliac crest, go more oblique, enter the foramen higher, and you end up at the disc space. Okay? Like here. Disc herniation, you see the nerve is pushed posteriorly. I don't want to enter here. If you do interlaminar, you have to do something about the nerve here. You have to retract it or go between the dura and the nerve. And look at the iliac crest. Look how high the iliac crest is, okay? So how to enter? You probably want to enter like this. Some surgeons go through the iliac crest. Yeah, it's not necessary. It's not necessary. Look. You see, this is the trajectory I want to make. And then needle placement on the transverse process, but you have to go a little bit more to the SAP. Use your thumb CD, and you see I'm really high. I'm at the starting of the exiting nerve root. Okay. So that's the part where you have to awake the patient more. So make the patient less deep regarding the sedation. And then start to drill. Bigger drills, and you can see the medial pedicle line is here. And if I have my rongeur, I can easily grab the disc herniation. I don't have to go up to the midline. And this is how it looks. Epidural fat is coming already. If I see epidural fat, then I know the decompression is nearby. And if you see pulsations, then you know, okay, probably that's enough. Do I have to see the nerve always? I don't think so, because I have a lot of cases where I don't see the nerve and they are good post-operative, okay? So still you can see here that there's this material here. We have to remove that. And once you have removed that and you get pulsations, then probably you're fine. Probably you're fine. So I also believe in the cytokines. There are a lot of cytotoxic material in around the nerve structures. And by rinsing it, what we are doing, I think you rinse a lot of cytotoxic material away, and that is also part of the healing. Okay? So still working on the disc material, but I'm really not sure when the decompression is enough. I'm still working on that, but I will come up with data about that. Okay, this will last, I think, for bleeding. It can occur. You can increase the pressure. If that doesn't help, you can go and use the bipolar. Okay. So extraforaminal case, those are not easy. A lot of people think transforaminal surgery is excellent for foraminal and extraforaminal cases. They are not easy. If you want to do transforaminal surgery for extraforaminal disc herniation, you have to think even more about your trajectory. You have the exiting nerve root. You want to go below and lateral to the exiting nerve root. Okay, so the trajectory is very, very important. You can see here the disc herniation. Okay. This is your AP. This is the place I want to go, a little bit more closer to the midline. This is a little bit of the facet joint you can take. Enter in the zone where the disc herniation is, putting your sleeve, and then you can grab the disc herniation. Okay, you can go from caudal to cranial by moving your working channel. So left side, this is cranial, this is caudal, posterior, anterior. The exiting nerve root you will find here, okay? The transversing nerve root you will find there. Look how big fragments are coming out. Here you see epidural fat is coming, foraminal fat is coming. So I know I'm close to the decompression. And I often see a lot of surgeons going in, pushing really fast out. No, it's slow surgery. You have to go in, close your forceps, no leg pain, then retract. Go in, close your forceps, no leg pain, then retract. You can see here the exiting nerve root, okay? And I'm just caudal to it, and from the lateral side, I'm entering to remove the disc herniation. Is this painful? Yes, this can be very painful because I'm close to the dorsal root ganglion. Okay. Reasons for doing transforaminal surgery are the pain generators. Maybe I'll come back on that in the second presentation. So transforaminal surgery, I used to go from lateral, but I'm now migrating more to the medial line. So then you enter more oblique, and then I think that's more safe to enter the foramen. Okay. So I have another case. Inside out. Okay. We have the inside out technique, we have the outside in technique, and you have the outside out technique. So don't go into the disc. Just go, do your job, get out. Okay? This patient was operated in another hospital. Disc herniation, lateral recess stenosis. You can handle it at the same time. But if your planning of the trajectory is wrong, you end up with this. Okay? You can see here, there is where they entered the disc. Okay? You cannot remove this unless you are very skilled. You have some bendable rongeurs, but that's not what you want to do in the beginning. In the beginning, I would advise you try to go through the facet joint, end up somewhere here. Half in, half out. That's safe. Okay? We are in the spinal canal. The drilling has been done. I will not repeat that. And then we have the intraoperative picture. There's the disc herniation coming. And the question is always when to stop. I believe better is the enemy of good. And the surgeons who are saying at the last procedure, I got my complications. Why was it the last procedure? Why was it the last step? Why was it the last bite? Because after that, there was no bite anymore. Okay? That's the reason why it's the last one. So we are pushing up to the complication. And I believe that you have to stop before the last bite. Okay? So when to stop, I will come with data. That's my next step to find out. I think I will leave it here. Leave it for some questions because of the time. One thing I want to show you quickly is when you get a dural tear, what to do. If you have a dural tear, what do we do?
It's depending on the size of the tear.
Exactly.
And where is it?
And where is it? Okay? But from the transforaminal trajectory, I have never seen CSF leakage through the skin. And I've done 2,000 cases already. Okay? I have patients with a clinically orthostatic headache in patients which I knew they had CSF leakage. So we did a blood patch, fine. But if you see a dural tear at the operation, and probably therefore it's better to use staining, because likewise I didn't recognize that it was dura, and I damaged the dura. So I'm doubting, is this disc herniation? I don't know. Is it dura? Probably. But patient is not having pain. So I thought, well, we can pull. You see, I'm pulling really slowly. And then all of a sudden, we saw this. Okay? So what I do, I take a piece of taco seal. I put it in. I pack it up with another piece of taco seal. And I take out the working channel. And usually, it's enough. Very easy. And if you want to put in the taco seal, just take out your scope, wrap up the taco seal, push it in with the dilator, then go in, place it properly, and then come out again. Okay? So you see, I've packed up the defect, and then it's finished.